Well, the biggest issue that's come up about treatment strategies is, making that sort of decision about treatment or not, systemic treatment or not, based on tumor size alone doesn't really make a lot of sense. And the only variants where the histopathology makes a difference are extremely rare. So could we look at something else? And we know that tumor-infiltrating lymphocytes have been prognostic. And in fact, in some series, highly prognostic in small node-negative tumors, so T1A, B, and C. T1A, even you can find a subset, although the numbers are very small, which might have a slightly worse outcome. So there are a number of different trials, one in the US, at least two in Europe, that are looking at trying to stratify treatment based on tumor-infiltrating lymphocytes, mostly the cutoff being 50%, but in some cases, for example, in one of the trials being done in the Netherlands in very young patients under the age of 40, where we know the risk is higher, they're using a 75% cutoff because in their own data set, they saw that those patients had a very good outcome. One trial is looking at patients who have stage 1 node-negative TNBC and high TILs, and then following patients with ctDNA. So the patients who become positive or are positive at baseline are getting systemic therapy, but those who are negative are followed. And I think that all of these trials are really fascinating. The trial that's being done in the US by Priyanka Sharma is a phase 2 randomized trial, but in this trial, patients who have T1CN0 are eligible. Otherwise, all the rest of the patients have higher stage disease. And those patients are receiving an abbreviated chemotherapy with evaluation of response so that you could potentially sort of stratify the intensity of therapy based on TILs at the start and then response.